This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from BMC Neurology, published in 2026, titled Revision Rate and Postoperative Volume Development of Chronic Subdural Hematomas After Burr Hole Craniotomy in Combination with Tranexamic Acid versus Surgery Alone, a single-center propensity score-matched analysis.
This is a timely topic, Alara. Chronic subdural hematoma, or CSDH, is one of the most common neurosurgical conditions we see, especially with our aging population. While burr hole evacuation is the standard of care, those recurrence rates, ranging anywhere from 2% to nearly 40%, remain a major thorn in our side.
Exactly. And this study, coming out of the German Armed Forces Hospital in Ulm, explores whether we can pharmacologically dampen that recurrence using tranexamic acid, or TXA.
Before we dive into the data, let's talk pathophysiology. The paper does a great job of explaining why this isn't just a simple bleed. They describe the injury to the dural border cell layer, which triggers a local inflammatory response.
Right, and that leads to angiogenesis and the formation of these pathological thin-walled capillaries. These capillaries are incredibly prone to rupture, causing recurrent microhemorrhages. The paper specifically highlights plasminogen-activated hyperfibrinolysis of the hematoma content as an acute phase reaction that impairs clot formation. It's a self-perpetuating cycle of cellular proliferation, angiogenesis, and hyperfibrinolysis.
And that's where TXA comes in. As an anti-fibrinolytic agent, it inhibits plasminogen activation. The theory is that by suppressing hyperfibrinolysis, we might stop that cycle and prevent the hematoma from re-expanding.
But it's been controversial. Some studies suggest it works, while others, like those mentioned in the paper's introduction, have reported no significant reduction or even concerns about increased mortality. So this team performed a retrospective cohort study from 2012 to 2024 to get more clarity.
They used propensity score matching, which I appreciate. It helps balance those baseline characteristics that often muddy retrospective data. What did the final cohorts look like?
After one-to-one matching, they had 73 patients in the TXA group and 73 in the control group. All patients were adults who underwent burr hole evacuation with subdural drainage. The intervention group received oral TXA starting within 48 hours post-op and continued it for at least 30 days. No intravenous loading dose was used.
That's an important clinical detail, 30 days of oral therapy. Now let's get to the primary outcome, revision surgery for recurrence within 3 months. What did they find?
The results were quite compelling. Revision surgery within 90 days occurred in 8.2% of the TXA group compared to 19.2% in the control group. That's an odds ratio of 0.40, with a p-value of 0.042.
Nods. An 11% absolute reduction is clinically significant. However, I noticed the authors were cautious in their interpretation. They mentioned the confidence interval, 0.14 to 1.12, marginally crossed unity.
Correct. Because it crossed 1.0, they noted the findings have limited precision and should be regarded as hypothesis-generating rather than definitive. Still, the numerical trend is hard to ignore.
What about the timing of these recurrences? If I'm a resident on call, when should I be worried about these patients coming back?
The median time to revision was actually quite early in both groups, 8 days in the TXA group and 11 days in the control group.
Interesting. Now let's talk about volume. This study didn't just look at whether patients needed surgery, they looked at the postoperative volume development. This is a deeper dive than many previous studies.
This was a bit of a surprise. Despite the lower revision rate in the TXA group, the researchers found that preoperative, postoperative, and 1-month follow-up hematoma volumes were actually comparable between the two groups. There was no significant difference in the absolute volume reduction detected.
That is a bit of a paradox, isn't it? If the revision rate is lower, you'd expect the volumes to be smaller. How do the authors reconcile that?
They suggest that TXA might not necessarily speed up the absorption of the existing fluid collection, but rather it stabilizes the environment to prevent the sudden re-expansion or acute microhemorrhages that trigger a symptomatic recurrence. Essentially, TXA doesn't act as a vacuum for the fluid, it acts as a sealant against new bleeding.
That makes sense from a neurosurgical perspective. We're often more concerned with the tension and the shift caused by a rebleed than the presence of some residual, stable fluid.
Exactly. Now, turning to safety, which is always the concern with antifibrinolytics in an elderly population prone to thromboembolic events, what did the mortality data show? It was very encouraging. Mortality was actually numerically lower in the TXA group. In fact, no deaths were observed in the TXA group, compared with 1 death, or 1.4% in the control group.
So in this specific cohort, they didn't see the safety signal that some previous critics of TXA have feared.
Right. To summarize their conclusion, postoperative adjuvant TXA therapy was associated with a lower rate of recurrence requiring revision surgery, without an observed increase in mortality. But again, they emphasize that TXA did not significantly influence short-term hematoma volume reduction.
It's a solid piece of work. For the residents listening, what are the key takeaways for clinical practice?
I think the key is recognizing the protocol. It was oral TXA, started early post-op and continued for a month. While we wait for large-scale prospective randomized studies to confirm this and define the optimal dosing strategies the authors mention, this study provides strong evidence that targeting hyperfibrinolysis is a viable strategy to reduce our revision rates.
It also reminds us that CSDH is a dynamic biological process, not just a mechanical problem. If we only treat it with a drill, we're missing half the battle.
Well said, Dr. Aris.
That's all for today's episode. We hope this deep dive into the 2026 BMC Neurology paper helps you in your next clinic or on your next rounds. I'm Dr. Aris.
And I'm Dr. Alara. Thanks for listening to the Neurosurgery Hub podcast. We'll see you next time.